started with the session now. That is antimicrobial resistance in the backdrop of COVID-19. Where are we and what is next? And to talk on this, a collaborative effort by REACT, Infectious Control Academy of India, WHO India Office and Superheroes Against Superbugs. And this session is moderated by Dr. T. Gangadhar, OSD to CM, Government of Telangana. And I request Dr. T. Gangadhar to please come up on stage. Can we have a huge round of applause for him? Screen, we have Dr. Balaji Veeraraghavan, Professor Clinical Microbiology.
As of all of us, we should know and understand these policies very well to roll out into the public utility. And because of that, actually, these sort of sessions are needed. And my introduction was told as OSD to CM, but I'm also a nephrologist and head of the Department of Nephrology in NIMS. And altogether, I think we also have other esteemed speakers lined up today. We try to discuss all these issues, put into the perspective of the government, where implementation policies are done, where implementation is going to happen. So, all the topics are very essential to understand for implementation. The first topic is presented by Dr. Balaji Veeraraghavan, Professor of Clinical Microbiology, CMC Vellore, on antimicrobial surveillance from national and hospital perspective. And it's a very important topic. I request Dr. Balaji to go ahead. Thank you, sir.
Thank you, Doctor, for your kind words. Everyone, for the next few minutes, I am going to talk about antimicrobial resistance surveillance, national and hospital perspective. Next slide, please. Next slide, please. Sorry. Okay, what is antimicrobial resistance? Antimicrobial resistance occurs when an antibiotic lost its ability to effectively control or kill bacteria. So essentially, it loses its potency, and no more the antibiotic can kill or control the bacteria. So in other words, if I have to simplify, in presence of antibiotics, the organism continues to multiply and disseminate. So what happens is, in this scenario, there is an increase in the antimicrobial resistance, and on the other hand, there is a limited number of new antimicrobial discovery. So when there is an imbalance between increase and decrease in the newer antimicrobial, then it becomes a problematic scenario. That's what we are going to see and discuss for the next 20 minutes. So I would like to say a few things about the principle of resistance. Resistance is progressively evolving from low levels to high level. Overnight, it's not an abrupt event which is going to occur. So cumulatively, it's going to happen proportionate to the selection pressure or proportionate to the dissemination of the MDR bugs. So it's always overnight, it doesn't happen, gradually it goes on. And another important point is antibiotic do not cause mutation. So antibiotic doesn't cause mutation. It's a natural evolving property is the formation of the mutation. What is antibiotic, how it contributes it selects the mutation. So the best example I can give is, you can see in this picture, any collection of organisms, bacteria, will have susceptible wild strains. Among the wild strain, when it gets exposed to antibiotic, gradually over time, among the collections, among millions of 10 to the power of 6 or 10 to the power of 7 organisms, 1 or 2 will mutate and it will show resistant characters. So gradually that happens on exposure to antibiotics. So when this gradually, naturally, when it evolves and the antibiotic is given to treat that individual, what happens is, on giving antibiotic, all the susceptible ones, all the yellow dots gets disappeared. And selectively, the mutated ones, the resistant ones amplifies. And this gets transmitted or disseminated, and that becomes the over time in a community or in an hospital becomes the predominant spreading bacteria. So by misuse and overuse of antibiotics, we are promoting this antibiotic selection pressure, and inevitably that results in the MDR and the XDR bugs, which becomes very difficult to treat as there is no new antibiotic coming to the market, or there is a delay in the development of the new antibiotic. So antibiotic pressure is the major driver of resistance. So we will revisit the principles. And the third important resistant principle is the organism resistant to one drug are likely to develop resistance to other drugs also. What happens is the organism has got in the plasmids they will have a gene for resistant to that particular drug. If it comes across another bacteria resistant to another class of drug, and there is an exchange or acquisition of that gene to the first bacteria, then there will have accumulation of multiple antimicrobial genes in the plasmids or in the cassettes, which will code from a monotherapy resistant to multi-drug therapy. That's why we call it as multi-drug resistance. And the fourth important is the antibiotic has got a unique property, that is use of antibiotic in one person affects other. So this doesn't happen with antihypertensives or anti-diabetic drugs. Here this happens for antibiotic for the simple reason, whenever the E. coli becomes resistant to for amoxicillin, and you know that billions of E. coli are there as a commensal flora in our intestine. So it transmits into the intestinal flora, and when it gets mixed up and gets excreted, then it moves on to it. So E. coli, Klebsiella, most of the entering bacteria acts as an resistant gene traffics, where it can acquire and it can pass on to the other bugs. So that's how use of antibiotic in one person affects the other. So I will skip this. So why antimicrobial resistance are so high in India? India is the epicenter of antimicrobial resistance in volume wise and the percentage wise. In the Southeast Asia, we don't know the true picture of China. Probably even China may have a similar picture, but definitely the other countries with the high burden of antimicrobial resistance are Greece, Italy, and most of the European and North American countries don't have. It's very too low, I can say, antimicrobial resistance. Why it's more in India is because of the huge burden of infectious disease. Mainly diarrhea, pneumonia, hospital-acquired infection contributes enormously. This is supported by poor sanitation condition, poor infection control practice, hygiene, malnutrition. So these are all the additional factors which contributes for, and more in middle low income countries, there is a lot of animal and human interface where the multi-drug resistant and extremely drug resistant dissemination is there. What are the drivers of antimicrobial resistance? The most important is rising income in the low middle income countries, and the cheaper generic antibiotics are available. You know that earlier for simple cold, cough, diarrhea, they take some home remedies and they get rid of it. Usually they don't go for an antibiotic nowadays because they can afford, and since unregulated over the counter antibiotic dispersion is there, people could afford because it's cheap, they can go collect and they have antibiotics which is not indicated for. And discriminate antibiotic use in animals. In the last decade, there is an enormous use of antibiotics in the food animals, poultry especially, where to promote the weight and growth of the animal in a short span of period, since it gives a good return, they use indiscriminately antibiotics in the livestock, especially poultry. And there is no need to mention that there is a huge inappropriate antibiotic use in the healthcare, because majority of the time they don't go by evidence based. Most of the time empirically treated, and especially in a poor infrastructure facility, healthcare facility, they have a very little chance to do the investigation, or they don't have much of a laboratory support to generate the evidence. So most of the time, in case infection is there, in that situation, people use antibiotics. And of course, inadequate public health and infection control measures also adds up to the burden of antimicrobial resistance throughout the world, and especially in the low middle income countries and countries with overpopulation like India. Okay. So this has been recognized as a major problem. The WHO came into a picture, and they have classified the priority pathogens of AMR. They have classified as critical, I, and medium. Critical, that is carbapenem resistant Acinetobacter baumannii, carbapenem resistant Pseudomonas aeruginosa, carbapenem resistant Enterobacterus. These are all the critical pathogens which requires immediate attention and drug discovery to combat this. And second priority is stratified as I. This includes vancomycin resistant Enterococcus faecium, methicillin resistant or vancomycin intermediate staph aureus, clarithromycin resistant H. pylori, fluoroquinolone resistant Campylobacter. So actually for H. pylori and Campylobacter in India we don't know the true prevalence or the problem burden, whereas for Salmonella fluoroquinolone resistant fairly we have an idea, and for sure we know that fluoroquinolone resistant falls in the intermediate category for almost 98% of the Salmonella typhi in India. And again for Neisseria gonorrhea, third generation cephalosporin resistant or fluoroquinolone resistant, we don't have much data in India. And the medium category, that is priority 3, is Streptococcus pneumonia, that are all non-susceptible to penicillin. Again, ampicillin resistant to Haemophilus influenza and fluoroquinolone resistant Shigella. So, whatever has been proposed by the WHO holds true for India too. And the WHO has come out with a global action plan. They have suggested 5 components and subcomponents to deal with this rising antimicrobial resistance and preserve the existing antibiotic for the next generation, and as well as to promote the discovery of the new antibiotics. So the second important component is the knowledge and evidence, and under the knowledge and evidence they suggest surveillance of for antimicrobial resistance. And way back in India in 1999, the World Health Organization led by Dr. Anuj Sharma initiated this activity as a program called INSAR, Indian Network for Antimicrobial Resistance Surveillance. And subsequently, after 6 years of network generating the data, this has been taken over by the Indian Council of Medical Research, and now the surveillance activity is carried out by ICMR, and I will be sharing the generated data by the ICMR for the past 7 to 8 years. So, what we have identified before the network, what made the network to commence this surveillance program is, number one is, most of the data, what was available at the time in India is small lab-based studies and medical college data. So that was not reflecting the geographical area nor the region of the country, and there was no uniformity in the methodology, and the methodology was not robust. So validation of the data generated was poor, and most of the time it was not representing the secular trend or pattern in general population, as the data are from a small tertiary care centers, and it was generated only from the very sick patients. And there was a need for national wide understanding of the drug resistant mechanism, pattern, clonality. So for this reason, to guide the treatment and prevention intervention based on the country specific scientific evidence at all level of healthcare, the surveillance was instituted initially by the WHO under the leadership of Dr. Anuj, who will be speaking subsequently in this session. From him, the ICMR has taken over, and with our prior experience, they have recognized and asked the CMC Vellore to take the leadership for non-fermenters and diarrhea-genic pathogens. And for enteric fever group, All India Institute of Medical Science was chosen. And for Enterobacteriaceae, it's the PJ Chandigarh. And for Staph aureus, it's Jipmer Pondicherry. You can see the 4 red stars. They are the nodal centers. And all the 4 red dots reports to the ICMR headquarters, that is the green star. And we do receive isolates from all the yellow dots across the country representing that region as in the capacity of regional centers. So from the regional centers, it comes to the nodal center. From the nodal center, it goes to the ICMR. So this is how the surveillance for antimicrobial resistance is carried out for the past 7 years in the country. And the ICMR has initiatives includes standardization and uniformity of specimen collection, identification of the processing of the specimen, identification of the pathogen, and the antimicrobial susceptibility of the high priority pathogens. And for that, they have given hands-on training and the standard operating procedures were developed and circulated. And similarly for antifungal also it has been developed and circulated. And to continue the robust quality data to be generated, external quality assurance was provided for all the regional and the nodal centers. And beyond the identification characterization phenotypically, even genotypic characterization for the antimicrobial resistance, that is antimicrobial resistant characterization, was carried out using next generation sequencing. And as well, additional data management in real time, ICMR has developed a program and all the centers were connected and they were generating the data in real time. Apart from the hospitals, the ICMR also took initiative in the name of One Health initiative, which includes similar kind of activity in the animal husbandry under the aegis of FAO, where again the specimen collection, lab diagnosis, resistant surveillance, EQUAS, everything has been initiated, similar to what they have done for the humans. Then they have made a proposal to ban the cholesterol use in the food animal through the Government of India order. As well, ICMR has undertaken initiative to develop rapid diagnostic kits and validate those kits so that evidence-based early detection and appropriate therapy are instituted, whereby misuse and overuse of antibiotics is avoided. So that they have taken as another scheme, and there was a separate vertical program for antimicrobial stewardship has been initiated with the formulation of the guidelines for assessment, formulation of guidelines, and training in various hospitals at all the levels, primary, secondary, and tertiary levels. So these were all the ICMR initiative. In addition to that, ICMR aims jointly with the CDC under the global health security agenda. They have collaborated to strengthen the healthcare facility for infection prevention control programs and to implement the standardized surveillance of healthcare associated infections, and to understand the antimicrobial use practice and to promote the antimicrobial stewardship for rational use, and also to support this activity through robust activity with the good quality, external quality assurance were instituted. And as well, they have improved the capacity to respond to the outbreaks of AMR infection related to healthcare delivery was their objective, and these are all being carried out for the past 5 years in the country. So with this background, I would like to say, show you and share the AMR scenario in India. For the past 7 years, what we were generating, I would like to share. And we do have, in India have a major problem with the gram negatives than gram positives. This is one of the important slides where it shows the important pathogens and the resistant percentage and the enzyme responsible for the resistance. So here you can see the first column with the organism, second column with the ESBL or cephalosporin resistant, third column for carbapenem resistant, and fourth for cholesterol resistance. In E. coli, you can see majority of the E. coli are almost 70% resistant to cephalosporins with the 10 OXA1 and CPXL15, and 10% are carbapenem resistant. The enzyme responsible is 90% due to NDM and 10% due to OXA48 like, and the cholesterol resistant among the carbapenem resistant is 8%. For Klebsiella pneumonia, it's 60% ESBL, and you can see here it's very important. The carbapenemase resistant is 40%, and mostly it's due to OXA48 30%, and remaining 50% is both OXA48 like and the NDM, and 10% is only NDM. And among the 40% carbapenemase resistant, 37% are resistant to cholesterol. Pseudomonas aeruginosa, here it's not mainly due to ESBL and carbapenemase. Rather, the first contributor for resistance to Pseudomonas aeruginosa is due to efflux pump and porin deficiency. In addition to the efflux pump and porin deficiency, 25% ESBL mainly due to Web, and 25% carbapenemase resistant mainly due to NDM followed by Vim and DIM. And of this 25% carbapenemase resistant, less than 5% are resistant to cholesterol. And the most superbug among the gram negatives, irrespective of the treatment, 40% mortality is seen with the Acinetobacter baumannii. And it's what I said, it supports with the figure here. You can see cephalosporin resistant is almost 80%, and carbapenemase resistant is also 80%, and it's mainly due to OXA23 and 24 on NDM. So the only drug of choice is cholesterol, which is less than 5%. So how do you treat this XDR bugs? Why the WHO has given a red alert and asking us to do the surveillance and expediting the drug discovery is, you can see from this, the extremely drug resistant bugs of E. coli, Klebsiella, Pseudomonas and Acinetobacter baumannii. We are seeing in E. coli and Klebsiella NDM, OXA48 and PB3 insertion, where you have no choice. The only choice left over is tigecycline or cholesterol. Tigecycline cholesterol is very challenging to achieve optimum concentration in the serum. It achieves very suboptimal concentration. So we are not sure about the successfulness of this therapy. Now, off-label use, we are doing ceftazidime avibactam plus aztreonam. It works, but we are not sure for how long this will last, and this is not an approved indication. Cefiderocol is another drug which will be effective. Unfortunately, it's not available in India. So we have a very limited option. When thousands and lakhs of people every day with this E. coli septicemia, bloodstream infection, they were in the ICU. We have a very limited choice. Again, with Pseudomonas aeruginosa, with moderate susceptibility, ceftazidime avibactam alone is available in India. Ceftolozane tazobactam, imipenem relibactam, which can be good drug but not available in India. And the major difference between our country and other countries is Pseudomonas aeruginosa, apart from efflux pump and porin, we do have in addition metallo-beta-lactamase. So we have only one choice, that is cholesterol, and cefiderocol we don't have. So we have a very limited, it's really scary to have a XDR Pseudomonas aeruginosa. And of course, Acinetobacter baumannii, as I mentioned to you earlier, so far nowhere in the world specific drugs are available to treat OXA23. So invariably cholesterol plus another highly susceptible drug they do give, so not highly susceptible, that moderately good drug they give. Whatever said and done, definitely XDR Acinetobacter baumannii, the mortality rate is 40%. Cefiderocol is a good choice, but not available in India. We don't know when in India we will get the cefiderocol. When developing nations has got a cefiderocol almost for the past 6 months they do have, but unfortunately we don't have. So now we are left with only cholesterol to treat all the 3 XDR bugs. If we use cholesterol, what will be there? That's the question. And you can see here, cholesterol use nephrotoxicity is almost 40%. Either cholesterol or polymyxin B. Both causes 40% cholesterol resistance, nephrotoxicity. Even mild cases of cholesterol associated nephrotoxin are being linked to variety of adverse outcomes. These adverse outcomes include increased in-hospital mortality, length of stay, need for renal replacement therapy, and increased healthcare resource utilization and post-discharge. So even though we have no other choice when we use colistin, even the therapy comes with a huge price of all these four factors. So, as of now, in the surveillance, the ICMR surveillance and the National Center for Disease Surveillance and the WHO supported glass pathogen surveillance in coordination with the NCDC are all going up and well. And I think I should say that the surveillance at present is in an excellent condition. Infection control and antimicrobial stewardship programs also making a good progress, as well as now we are very certain what resistance mechanism and the transmission dynamics unique to India it's happening. We are fairly have a good knowledge about that. The gaps are data only from the tertiary care hospitals, not representative of the entire country, and moreover community data is totally missing. And surveillance in animals is missing, but it has been initiated. It may take some time to get the data. And the data on antibiotic use are not forthcoming, so additional effort required. And education and awareness are not optimal. I think that is one area where a lot of progress has to be made. And of course, One Health initiative, it's in a very infant stage. We need to go a long way. So, way forward is to build a good stewardship practice to improve the quality of antimicrobial prescription in the outpatient, inpatient, in the primary, secondary, and tertiary levels, and to strengthen the infection control. And also, it's imperative to have an innovative ideas to address infection control in nosocomial settings. And of course, to support both antimicrobial stewardship and infection control program, you need to have a robust diagnostic stewardship. So that is another requirement. And the other requirements includes sustain and strengthen the quality data collection, where it's not enough for 16 centers for such a huge population and a big country. And One Health approach, where antibiotic resistant data from the livestock, especially from the poultry and the environment, are required. And we need to be much more dynamic in collecting the real-time informations and the dynamics, and so that we can better understand the antimicrobial resistance in the country, and we can do appropriate initiative for an appropriate therapy. With this, I would like to complete my talk. Thank you. Thanks for your patience.
Thank you very much, Dr. Balaji. You rightly illustrated all the points, but few points I'd like to make, sir. Actually, what are the pertinent points raised by Dr. Balaji are, number one is surveillance. Surveillance needs testing. COVID, all of us, we know that actually because of testing only we know the problem where it lies, where tracking can be done and treatment can be done. Like that, the point which he was trying to make out is only tertiary care hospitals are contributing to the surveillance program. So in COVID, actually my suggestion to Dr. Anuj, who is sitting in front of me, is the government of India is supporting the district virology labs under emergency COVID response program, where actually the governments are setting up the district virology labs. Apart from virology labs, in the districts we should have microbiology labs also. We should be provided with the equipment and manpower to do the culture facility. So until unless we do that, so the nation, what Dr. Balaji was trying to tell, for the country like us, only few centers will not be sufficient. In the COVID also we had the same problem. To start with, the testing was very low. Now in lakhs of lakhs testing we are doing. So if at all as a country we think together, I think this should not be a problem, where a culture facility, the microbiological lab facility is extended to the districts, where a clinician, before starting any antimicrobial therapy, he will try to send the culture and then start therapy. Otherwise, the problem is actually he'll choose the antibiotic which is available to him, which is accessible to the patient. So because actually as the data presented, cephalosporins, carbapenems and colistin, they're having some resistance already emerging in India. And because of the lack of these diagnostic facilities, we are, as a clinician, we are forced to prescribe the medication, because we cannot wait. We cannot send a culture to the Hyderabad or a district, from district to state capital to get the culture and start the treatment. Like COVID also, we learned a lot of things from COVID. So I think suggestion from our point of view is to suggest to the government of India to establish district microbiology labs under this antimicrobial stewardship program, fund the state governments in a mission mode manner under NHM, so that actually the capacity will develop, the data will emerge that can guide the future therapies. So thank you very much, sir. I think we move on to the second presentation. So in the questions will be taken in the last. The second.
Dr. Anuj Sharma, Technical Officer, Antimicrobial Resistance, Health Laboratories, Infection Prevention and Control, World Health Organization, Country Office for India, to please come up on stage, who is going to speak on the topic of AMR Global Action Plan, National Action Plan. Okay. Yes. May I all stage?
Hi, Dr. Sujith.
Surveillance, I think we should go to the stewardship regarding the usage of antimicrobials. Over to Dr. Rupali, ma'am.
That we couldn't be there with you. Hyderabad is actually my hometown, so I always look forward to coming there. Disclaimer, I'm an infectious disease physician, and a lot of what we do with regard to stewardship is very practical. And as the session chair had alluded to, antibiotic stewardship needs to be practiced at the bedside. So I'm kind of going to give you a bit of flavor of that. And I'm not going to be dealing with the national perspective, because we have very eminent speakers speaking on that. We have Dr. Sujith Chandy, a colleague, a dear friend who has been our mentor with regard to stewardship, as well as Dr. Anuj Sharma, who I've had the pleasure to meet on many occasions when we were deciding the priority packaging fellows. So I'm going to give you a very hospital-like perspective. A lot of these principles would be applicable across, whether you apply it to a hospital, whether you apply it to a healthcare setting, whether you apply it to a state or to a nation. So I think I'm going to take you through the basics first. I realize it's a mixed audience, and being cognizant of that, I'm going to take you through a few basics, and then really what do I do in my daily clinical practice as I go practice stewardship. So antibiotic stewardship, what is it, and why do we need it? Does it work? I think the why part of it has been very eloquently taken through by Dr. Balaji. But does it work? I think that's the question that we are here to answer. What do we mean really by rational antibiotic use? What are the goals and implementations of an AMC program that we need to strive towards? A few quick practical examples in the outpatient setting. I'm not taking you through very complicated inpatient setting, which is actually what we deal with on a day-to-day basis in a tertiary care hospital. And really, if you implement a tight stewardship program, does it work? And this is some work that we have actually done in India. So bacteria are there everywhere. So what are the various things that we can use? And I think this is a very simple guide. I urge all of you to read it. Dr. Dilip Nathwani is the author of this book called The Practical Guide to Antimicrobial Stewardship in Hospitals. It's a very simple, very elegantly written book. There are, of course, guidelines by the Infectious Diseases Society of America and the Society of Healthcare Epidemiology of America. Dr. Balaji has already alluded to an ICMR AMSP initiative on which actually both of us have authored a book, predominantly him actually, with regard to antimicrobial stewardship in 2018. So that's again a very good guide to actually implement a program in your hospital. So what really is antibiotic stewardship? So it is just a coordinated set of interventions which are designed to improve and measure, and I think that is a very important word here. We have to measure the appropriate use of antibiotics. How do we do it? We promote the selection of the optimal antibiotic, the correct dose, duration, and the route of administration. At the end of it, want to lead to improve patient outcomes, and we want to decrease the adverse events that we see, we can use a variety of inventories. With most people abroad use Clostridium difficile infections, or they use antimicrobial resistance rates. As you know, already resistance rates are pretty high with regard to gram-negatives. So those could be some of the things that we could look forward to. Unfortunately, decreasing the antimicrobial resistance rates is something that we can look forward to much, much later once the stewardship program hasn't been in place for many, many years. So, yes, there is a dry antibiotic pipeline, the increasing rates of AMR, and Dr. Balaji has alluded to many of these. This is an older map, but just to say we are nowhere any better than we were at that point in time. So this is 2015. 6 years from now, we're still very much in the same position. So it is scary and it's looming large. And you will have seen various versions of this graph. It shows you a very scary version of how very few antibiotics are available. And even if they are available, unfortunately, most of the time they're available abroad. Access to antibiotics which work in a gram-negative setting for a working clinician is very, very difficult today. How do we combat antimicrobial resistance? And the one important pillar is optimizing the use of existing antimicrobial agents, apart from, of course, preventing the transmission of drug-resistant organisms through good infection control programs and improving environmental contamination. Really, does it work? And this is a very nice graph taken from this particular article from Dr. Nathwani's book, and I love this graph because it very clearly demonstrates how a stewardship program can work. So if you look at it, the blue bars there are the Clostridium difficile associated diarrhea infections, and you can see here how the incidence is coming down. So when you just instituted infection control methods, really didn't make any kind of difference. When you introduce an antibiotic optimization intervention, there is a dramatic decrease in the Clostridium difficile diarrhea. So it's just one of the outcomes that you can use to measure whether your stewardship intervention is working. What happens to resistance? It does take time. Like I said, it's nothing that happens overnight. So you can see here, this is a hospital in the first panel there. They looked at the fluoroquinolone consumption. And what they did was they decreased, they implemented a restricted use of fluoroquinolones in 2000. And you can see here, it took almost 10 years for Pseudomonas resistance to actually come down compared to just monitoring it just like that. So you can see here whether it's fluoroquinolone resistant Pseudomonas aeruginosa or methicillin resistant Staph aureus. It took nearly 10 years for any kind of resistance to come down, but it did. It definitely did come down. So what are the various steps that we can use to implement an antibiotic stewardship program? So the first most important thing is actually making a diagnosis. I think very often we don't trust our clinical judgment. We have to trust our clinical judgment. We've all been taught in medical school how to make a diagnosis. So all of us have an intuition of what the diagnosis is likely to be, but we tend not to follow up on it. What we do is we just cover our bases and practice medicine where we are just covering 4 different diagnoses. The second thing we need to do is have a method or mechanism of confirming the diagnosis, and that can only be obtained by doing appropriate diagnostic tests. I've just mentioned cultures here, but there may be a variety of maybe a serology, maybe a throat swab, maybe a nasal swab, and of course appropriate cultures, whether they're blood, sterile body sites, pus. When you're taking a culture of an unsterile body site, be aware of the fact that it could be a colonizer or a contaminant rather than really a true pathogen. So we are treating, we're physicians who are treating patients, we're not treating fevers, we're not treating WBC counts, we're not treating procalcitonin levels, we're not treating infiltrate on a chest x-ray, and we're not treating culture reports. Limit empiric therapy. There are very, very few situations where you have to go in guns blazing with empiric therapy and broad spectrum antibiotics. And that is only seriously ill patients. And actually, if you look at seriously ill patients, there are only 6 categories of seriously ill patients. Febrile neutropenia, we will argue with you, severe sepsis and septic shock, acute bacterial meningitis, community-acquired pneumonia, ventilator-associated pneumonia, and necrotizing fasciitis. So these are the 6 categories where, yes, after taking appropriate cultures, you can go ahead and start weekly evaluating it. Now we know that in most cases, 48 to 72 hours, you have a culture. Once you get a culture report back, I think we all forget to, focus. We can get probably a true diagnosis, maybe we get a pathogen that is isolated, or maybe we don't get a pathogen. But either way, the clinical status of the patient and the cultures, or the diagnostic tests, serologies, or whatever it is that you're using, will help you to focus the antibiotic use. Third thing is know your bugs, hospital antibiograms, and I think that has been made possible to a certain extent by the network that Dr. Balaji was talking about, the ICMR network, which is helping everyone to be able to create a hospital antibiogram. And there are various programs which I'm sure Dr. Anuj will talk to you about, like the PHIC, which will help you to create a hospital antibiogram. Whenever you're using antibiotics, please use the correct dose. There's nothing like a strong or weak antibiotic. Use full therapeutic doses as has been advised for killing the appropriate pathogen. When loading doses are required, please use loading doses. When continuous infusions are required, please use continuous infusion. And to actually appropriately target these, you really need to know the optimum PKBD parameters for you to be able to optimize it. De-escalation. Now, very often this is a thing that is not often practiced, whether it's in the ICUs or in the ward. Once the patient is better, we're all happy, and we say, oh, because of that antibiotic, the patient improved. Very often, it's probably in spite of the antibiotic rather than because of the antibiotics. So go according to the AAC report, go according to the patient's status, stop antibiotics when it's not necessary. Try and combine to a single agent, try and de-escalate from a broad to a narrow agent. When IV is not necessary, please de-escalate to oral. All of these have a remarkable effect with regard to the antibiotic flora that is present in your gut. Very often what we're told by intensivists, oh no, the patient improved because of an antibiotic. But you will find a culture which is fan susceptible and they can easily manage the antibiotic. So there is actually enough data to show that de-escalation is feasible and safe even in the sickest of sick patients. Febrile neutropenia with severe sepsis actually has a mortality benefit, and that needs to be taken into consideration. So what are the goals of the program? We want to improve patient outcomes. Most of all, that's the most important thing. It is a matter of patient safety, and that is a message to be given to every hospital administration. This is a patient safety priority. It's not just about the outcome as well. Antibiotics are not really harmless. It reduces resistance and eventually will reduce the healthcare costs as well, because each patient who can't pay for a very expensive antibiotic puts pressure on the health system. So there are a variety of ways as to how you can implement a stewardship program. So what are the evidence-based interventions that have proven to reduce resistance? So you look at it, these are the core strategies. So if you restrict the antibiotic, so let's say you don't have an antibiotic in your formulary, the chances of physicians are not going to prescribe it. Pre-authorization, if you have a method where if you give an antibiotic where it has to be pre-authorized by some infectious disease physician, that really works. Prospective audit with intervention and feedback, a little more painful. That is, you wait for 48 hours, see if the team is going to de-escalate. If not, you go back and check and dialogue with them and give them proof as to why they need to de-escalate. Most of all, a multidisciplinary stewardship team. A doctor alone will not manage. You need a pharmacist, you need a microbiologist, you need an epidemiologist, you need an IT staff, you need to have a nurse to make sure that the cultures are actually set. Now, yes, those optimizations, streamlining, parenteral to oral conversion, guidelines, clinical pathways, all of those are important. But all of these need to be taken together with a team in place to make a difference. So just a very simple thing, start smart and focus. It's a very, very simple thing. So you start the patient on antibiotic. That antibiotic decision should be made based on your hospital antibiogram, the clinical syndrome of the patient, and then make a choice about the right antibiotic. You then focus it. 48 hours later, you come back and say, was my diagnosis right? Was the antibiotic right? What is the likely pathogen that is likely to be there? What is the resistance profile that is likely to be there? And then you check the microbiology cultures or serology tests or whatever it is that you've sent, and then decide whether you want to stop, whether you want to switch from IV to oral, whether you want to change to a narrow spectrum agent, or whether you want to continue the same thing because you're not quite sure and you'd like to review again. All of these are very, very important. And fifth, maybe you want to change them to an outpatient antibiotic therapy team. These are the situations when antibiotics can definitely be stopped. Viral pharyngitis, rhinosinusitis, bronchitis, just a non-infectious pulmonary disorders diagnosed as pneumonia, acute otitis media. Most of all these are usually viral. Skin and soft tissue infections. A subcutaneous abscess is not the same as an necrotizing fasciitis. A stasis dermatitis definitely does not need antibiotics. Asymptomatic bacteriuria, pyuria does not need it. Low-grade fevers, the first option should not be to start antibiotics, and of course, colonization and culture contamination. Duration of antibiotic therapy, there is enough and ample data, evidence-based, multiple Cochrane reviews, which tells you that short courses do work, and there are definitely situations where you can reduce the duration of the antibiotics. So whether it is 4 to 7 days in an intra-abdominal infection where the source has been cleaned out, or whether it's a community-acquired pneumonia where it's 5 days, definitely duration of antibiotics can be reduced. So these are the golden rules. Microbiology guides therapy whenever possible. Indications should be evidence-based, narrow spectrum, dosage appropriate to the site and the type of infection. There's no point using a drug which does not penetrate the site you're trying to target. Minimize the duration of therapy and ensure monotherapy in most cases. So very quickly, in the time that I have, I'm just going to give you, it's a pity that this is not a live session. This is a 21-year-old who presents with a nose block, a runny nose, watery eyes, sinus pain, scratchy sensation, and he's for the last 7 days. There's no fever, headache, vomiting, or cough. Now, this is a real scenario. He sees an ENT specialist, and the ENT specialist gives him levofloxacin 500 milligrams for 14 days. Which of these are correct? Is it shorten it to 14 days? You want to replace the levo with amoxicillin for 14. You want to replace it with amox for 5 days. You want to increase it to once daily for 5 days, or increase the dosage to 750 milligrams. Which of these are actually correct? So yes, I can hear people in the dials answering. So yes, none of the above is actually the right answer here, because this is actually a clear-cut viral rhinosinusitis. And just because the person has a little bit of prurigo sputum, that just indicates an increase in the WBCs, in the secretion. It does not indicate a bacterial superinfection. So what steps did we take towards this management? We made a diagnosis. We determined organisms which could cause the clinical syndrome. We decided which antibiotics could be required, and we chose the right antibiotic. This is the usual steps that we tend to take. So here we said it's viral, so really the antibiotic should be stopped. Let's say this is the second case. The 75-year-old male, low-grade fever, chest discomfort, cough after a seizure. His findings are unremarkable clinically, but he has a laboratory test which shows a TROP-T, which is more than 40 picograms per mil, and chest X-ray shows bilateral basal consolidation. So he's seen in the ER, but he's started on augmentin. What is the correct response here? Continue ampicillin sulbactam for 5 days, discontinue it, add azithromycin, or switch ceftriaxone. Which one do you think is the appropriate? So, as you know, the diagnosis here is a myocardial infarction, most likely, and really bilateral basal consolidations are consistent with a cardiac failure. He really does not need any kind of antibiotics, and we should actually be discontinuing the antibiotics here. Third patient, a little more common. Those two may be seen just in the ED, in the outpatient setting. This is a banker. She comes to hospital for suture removal of an umbilical hernia that was operated last week. She had a short-term Foley's catheterization, and she was operated for pulmonary hernia, and this was actually removed post-surgery. She doesn't have any major comorbidities, no fever, urinary complaints, her vitals are stable, nothing really here. So she has, for some reason, an overzealous intern decides to send off a urine culture. She comes back with the result, and this shows 100,000 positive colonies of E. coli, which are ESTEEMED. And you can see here, there's 100 pus cells, many GMPs. What is the next step here? I mean, when faced with this, I can tell you there will be many people who will actually start this patient with antibiotics. And the most important thing is they also thankfully set a urine routine at the same time. That only showed 14 cells, but RBCs were nil, protein was nil, glucose was nil, counts were normal, patient was asymptomatic. But horror of horrors, she's seen, and then there's some original symptom who sees and says, okay, this patient needs given antibiotics, starts the patient on meropenem. Believe me, this is a very common occurrence. But actually, what this patient really, did she really need these antibiotics, and what adverse effects have happened in this patient? So bacteriuria really is not a disease, and a midstream clean catch of urine does not decrease contamination. I think it's a known fact. So very, very important. A clinical diagnosis would have determined that a urine culture did not need to be sent in the first place. So for some reason it got sent, and once we got the result, everybody's panicking because it showed a culture that was problematic. So yes, antibiotics are not harmless. They can wipe out the wild caught flora, leaving multi-resistant bacteria to proliferate. It can predispose to Clostridium difficile colitis, candidemia, and it actually leaves the individual prone to a multi-resistant infection later on. And this is a very common scenario that we come across, especially in febrile neutropenia patients who receive one antibiotic after the other, and when they come the next time, you will find that the gut flora has completely changed and they end up getting the resistant infection. Now remember, this can be transmitted to other bacteria, this can lead to increased hospital, drug costs, patient costs, and can be extremely problematic. So, there should be, what are the keys to a success of an MSD program? There should be a clear aim and vision that stewardship is a patient safety priority. I think that is a very important thing to sell to any hospital administration. There has to be management support, and most importantly, an accountability. There should be a multi-professional antimicrobial stewardship team, strong influential clinical leader, effective communication structures, evidence-based stewardship interventions, and you have to plan measurement of these interventions. You have to educate, you have to innovate, and ensure that early short-term wins occur and consolidate. These are the various team members. I've already mentioned this. We need somebody who's a physician, who's strong, who has some training. They should have pharmacists who know what they're talking about. And of course, it should be a prescriber-led initiative. Unless the prescribers themselves are leading it, it's really not going to happen. Quality management staff monitoring it on a regular basis. And of course, we need microbiology lab, infection preventionists, IT staff, nurses, etc. I thought I'll just end with something that we had done in our hospital. We were trying to introduce a stewardship program, and as usual, this is quite a while ago, almost 6 to 7 years ago. And as usual, there was a lot of resistance to this, especially in the intensive care unit. So we got them on board and we said, look, we'll do a project where there's a baseline, where there's 6 months, where all we do is observe and we measure the antibiotic use. We have an intervention period where actually we see every patient with an antibiotics for more than 48 hours and give our advice as to whether it can be stopped. And this would be done by a physician and a pharmacist who have experience with the same. And then we thought we'll do a follow-up treatment. So we hypothesized a direct feedback will of course lead to a decrease in the antibiotic use. So this is what it was like. Our primary endpoint measure was days of therapy of antimicrobials. What we did is we took actually the medical ICU and the surgical ICU, and we took only patients when they were in an antimicrobial for more than 48 hours. So what we did was put in alerts. We saw the patient, we did a detailed examination, gave our opinions, and then we put in alerts into the workstation so that the physician, whenever they opened the clinical workstation, this would hit them. What we did find was remarkably our antibiotic use came down, carbapenem use dramatically decreased, our colistin use dramatically decreased, and definitely we thought that this actually demonstrated to them, showed it to the ICUs, and you can see here, what I didn't mention is in the follow-up phase, you can see here, if you look at the carbapenem duration per 1,000 hospital days, it was in the baseline was 426, in the intervention was 340, and the follow-up it was 407. So it was definitely less than what was there at the baseline. We felt that this was actually a major thing. What we found is the ICU and the treating teams themselves started putting in alerts themselves to remind themselves that the antibiotic needed to be stopped. So definitely it can happen, and it's a small thing to take. So consolidate treat all the wounds that you get, and then take it forward. I'm just going to summarize. Antimicrobial stewardship is a patient safety priority, dedicated multidisciplinary team with administrative commitment. Always start with low-hanging fruits, easy to do interventions like decreasing duration of therapy or de-escalation of therapy depending on cultures, and always measure the use or antibiotic use to determine success or failures. So definitely this is from WHO, of course, no action today, no cure tomorrow. This is my team, which actually used this as a team to run a marathon, which they actually won. Thank you for your attention.
Thank you, Dr. Rupali, for an excellent presentation on antimicrobial resistance. When we see the patient, we should have the clinical intuition, and also some of the point of care tests also should be there. I was discussing with Dr. Subbalakshmi Madam today. She was infectious diseases professor in Nizam Institute of Medical Sciences. Like, whenever we are framing a stewardship program, the clinician should be aided with some sort of investigations also. These investigations can be a point of care investigations, and other things can be in the lab. The turnover time also should be rapid to aid or strengthen the clinician to take a decision. Because a lot of times what happens, though we discuss about the stewardship program, in practicality, the patient will come to you and you have to decide. A clinician has to decide the treatment. So he should be aided well. Like in COVID also. So the rapid test is that when any patient comes to you, immediately you have a test, you do the test, whether it's a COVID or non-COVID, decide, based on that you treat. And you send a RT-PCR. That is also turnover time less than 24 hours. So like that, actually, these are whenever we try to implement some sort of a stewardship programs, we should also strengthen the end user also. Without strengthening the end users, this stewardship program may not be successful in the long term. So as Madam rightly told, intuitions are more powerful than the test. That is one thing. One more concept she rightly emphasized is a pre-authorization of the antibiotic usage. If at all a novel antibiotic is being used in a setup, that should be pre-authorized by a committee within the hospital setup. If at all I am trying to use a colistin for some as an antimicrobial agent, I should take a permission from a committee whether I can use it or not. I think this is also very, very practical suggestion what Madam made. I think we should also follow this sort of things. Making available rapid diagnosis tests to aid the clinician, strengthening the labs which will give the results within 24 hours, and having a committee to pre-authorize some sort of the costly medications and newer medications whenever you're trying to use in the clinician setups. I think a very excellent talk, ma'am. We'll try to implement whatever the suggestions that you have made, and the questions I think as per Rangareddy Garu will take in the end. Now we move on to the next presentation. Is one more interesting talk by Dr. Sujith Chandy on the use of antibiotics and use in community settings and for stewardship. Over to Dr. Sujith Chandy. He is a professor of clinical pharmacology in Christian Medical College. So over to you, Dr. Sujith Chandy, sir.
Yeah, sure. Thank you. One of the challenges.
Can you just the slideshow to be total screen, sir?
Yeah, one moment. Yeah, is that okay?
Yes, sir. Now it's fine, sir.
Yeah. One of the challenges of being far away and talking is that one cannot see the audience. I think as a teacher, that's often a very great disadvantage. But I must say that this is the same problem we face with antimicrobial resistance. It's in one sense a faceless enemy. We can see the microbes, and the microbiologists are fortunate enough to see them, but the rest of us cannot see the threat. And that is one of the reasons why for many decades, right from the time that Fleming actually said that there is going to be, the bugs will fight back and there will be a resistance, we've not been able to do as much as we need to do. But now we are in a crisis situation. In fact, as you rightly said, sir, COVID has taught us a lot of lessons over the last 1.5 years. But interestingly, in my opinion, AMR is a much bigger threat. It is going to be a continuous threat. It is going to pervade all walks of life in healthcare, right from cancer treatment to just normal treatment, to almost everything that one can think of. And this is why that all of us sitting there in that audience need to understand that this is going to amplify into such huge proportions, much more than COVID is today. And that is why we're all sitting here in this particular session. I'd like to thank Balaji and Priscilla for their excellent talks, putting into perspective what the problems are and also what is done in the hospital. But unfortunately, it's not just enough to try and tackle this huge problem in the hospital, because we know that a lot of antibiotic use and issues are there in the community, and we also know that there is antibiotic use at the One Health sector, all kinds of sectors, including the environment. So in this brief talk, I want to just allude to some of those aspects. I cannot cover everything, and hope that some of you who are sitting in the audience are not just working in the hospital, but also in public health and as leaders of the community can be inspired to do something for your state and the nation. Because unless we do something, and if you sit back and say, this is too big, we can't do anything, and we don't start, actually it will be too late. It will be something like climate change, which we are now at this point facing. So with that, I like to focus the fact that India is not unique. Many lower middle income countries are facing the same problem because of some of the same issues. A lot of it is because of awareness and understanding and resistance to behavioral change. And I must confess, I was pleasantly surprised when COVID happened, how the social media network as well as mainstream media highlighted the need for hygiene and washing hands. And you could see the kind of changes that happen in terms of awareness over a short period of time. But we need to have that sustained behavioral change over a longer period with AMR. Balaji has told us about the need for more surveillance. And also the importance of, we can't have a situation where for each infection we just take an antibiotic. Prevention is much better than cure. We know that, especially when in our pandemic time, when our hospitals became full, we know that prevention and some of the methods used at that time with social isolation and hand hygiene, etc., masking, all help to prevent an overload of the hospital system. Similarly, IPC with basic hygiene practices in the community is going to be extremely important, and it's but a challenge. We know that inappropriate use of antibiotics, huge amounts of fluoroquinolone, cephalosporins have been used in almost all sectors, and now of course colistin. And we know the challenges of void in discovery, because many pharmaceutical companies have migrated towards chronic disease treatment because it's more profitable, and I understand the business model. But the fact is that ID is a huge problem, and it's increasing. And last but not the least, what can we do in our various sectors, in our hospitals, in our communities, when we all know that there are huge challenges in finance, but there are also huge challenges in talking to one another and trying to have a cohesive approach. So these are the challenges that all of us face, not just in India. So I'm just going to try and put some things into perspective so that you can start trying things in your own communities. And this is not just about healthcare providers. There are other stakeholders we are talking about: the public, patients, policymakers, the industry, farmers at all levels, food industry, environment, and many others actually. So what I would like to propose is to have a mechanism, which I call it as ECM, where we can engage and enlighten, communicate and collaborate, move and provide momentum. What do I mean here? So I'm just going to talk, for example, here, with healthcare providers as a start. Many of you who are sitting in the audience are healthcare providers. I think all our professional associations, whichever specialty we belong to, we are all part of an association somewhere or the other. We, sitting in this audience, could become key players for awareness and stewardship. You understood some of the challenges, as Balaji said, and you now know that many of the times in simple infections, as Priscilla said, you really don't need to take an antibiotic. Are you able to highlight this particular message that has already been said by both of them to your professional associations? Can you become a champion? We all know that many hospitals are moving towards accreditation, and one of the same things that Priscilla highlighted was patient safety, and patient safety and accreditation often go together. So can this AMSP and the issue of AMR be taken as a challenge in your hospital when you look at accreditation? Make sure that you're on board as far as AMSP is concerned. We all know that the world thrives in competition, but then it also thrives, or rather the opposite, when there are negative issues being brought up. And unfortunately, hospital-acquired infections or hospital-associated infections is a difficult statistic to have in a hospital where people say because of bad practice, you've got bad hospital-acquired infection stats. So that is something that we can work on in a negative to positive incentive, if I can put it that way, to try and make your hospital and your community better. Some people would like ranking. I'm not a great fan of ranking, to be honest. But it does work when you know that you are up there in the first 10 and you want to stay there in the first 10. And last but not the least, having a hospital stewardship program will have tangible benefits, especially when it comes to cost and decreasing the stay of the patient when you're waiting to get the next patient into the bed. Of course, as a healthcare provider, you could have individual strategies, and you need to be able to, in your own associations and in your own settings, see what are the best practices in different departments, and can that be highlighted? When you meet together as different hospitals or communities, can you highlight this? And especially certain specialties who are really looking at this, can their success stories be highlighted? And of course, we all know that every specialty moves up. Medicine has moved up to various subspecialties, and infectious diseases become a subspecialty. But if we leave it alone to only the ID specialists, they are very few in number, even in a country like India. So that's not enough. Each physician, whether you're in the human field or in a veterinary field, may have to have a focused training on infectious diseases and the issue of AMSP. And that would help a lot in covering many of the gaps we have in human resource personnel. And this is not just related to doctors, but also please remember that the healthcare team has to be taken along as a whole if you really need to move forward with tackling AMR. So by that I mean pharmacists and nurse leaders, extremely important as far as infection controllers. Many of the hospitals, the nurse leaders are the ones responsible for infection control. Pharmacists are the ones ultimately dispensing these antibiotics, and often many of the doubts that patients have, whether it's inpatient or outpatient, finally they ask a pharmacist. I've seen many times when I just go to a pharmacy to get something, normal chemist shop outside, the number of patients who say, look, I've got a cold, I've got a cough, can you give me something? Now, if those pharmacists are not empowered or enabled or made aware of the issues of AMR, they could end up giving an antibiotic. So those kind of champions within each profession is important. Patients and public, we all know the challenges that they face. And this is just two, I work with a network called REACT, and this is just two workshops that we had with patients and public, understanding their perspectives and seeing what they could do, as well as understanding why things are often going wrong as far as awareness and behavioral change is concerned. So the group strategies with patients and public, I think one of the things that we all have to remember, it's easy to preach things because sometimes we don't understand context. If you ask somebody to wash their hands, but they don't actually have clean water to wash their hands, they may think that just eating straight without washing is much easier than going to a dirty pool and washing. So you've got to understand what the context that we talk these guidelines in. We understand the beliefs and the cultural issues. Many patients really do not understand what is an antibiotic, what is an infection, they all think that as soon as you have fever, you need to take a capsule-like drug which will be the treatment for fever. They don't understand the issue of AMR, they don't understand the issue of an antibiotic, but they all know that they want to take something in order to get better, and so they often just go to a pharmacy shop because they may not have the money to see a doctor, they may not have the access if you have to walk 20 kilometers in a rural setup to a healthcare facility. The other aspect that we really need to understand is many of the upper respiratory infections, fevers and diarrhea, which most people have, especially now it's in a rainy season, you don't need an antibiotic because 80% are viral. And therefore, those kind of community level initiatives to make people understand this is important. We need to engage as people who are in the know-how with self-help groups, mothers groups, health-related non-governmental organizations, because the government needs all the support that they can, because we really have to put this as a mass movement rather than just a hospital movement. And we need to be able to create demand in the public eye for hospitals with lower hospital-acquired infections. Then the healthcare leaders in those hospitals will make an effort to actually reduce their HAIs. Last but not the least, we need to understand that our body is made up of bacteria and water. Many of the bacteria, 90%, 95% of the bacteria are actually good. Did you realize that? So each time you take an antibiotic, we're actually killing many of our good bacteria, which are supposed to be protected. And I realized this very much with a particular article by Costello et al. And BMJ in 2009, where they showed in the primary care setup, if you take an antibiotic, especially broad-spectrum antibiotic, for around 6 months, your commensals are gone and that protection is not there. It takes around 6 months for the commensals, 6 to 9 months, to come back and give that protective effect. So there's a huge issue that the public needs to be aware of each time they take an antibiotic. Students are the lifeline of India and many LMICs. The young population is a huge population, the basic pyramid of a population pyramid. And they are the future. And if we do not target them and make them understand what issues we're dealing with as far as AMR, just like climate change, I think we're in for a bad problem. Now, the students, of course, there are medical students, there are pharmacy students, there are nursing students, there are veterinary students, but there are also normal arts and science students. And we have to have a delineation in how we deal with both. But overall, I think from a healthcare professional student point of view, the way that we teach often is very compartmentalized based on the exam. But it's time in AMR, which is a very complex phenomenon, to have a much more integrated model, an approach-based learning, where we learn more how to interpret a diagnostic test rather than drawing the bacteria and getting the full marks for that. Similarly, I always tell my students, every day of your life is going to be a test, not the one in the MBBS before you finish it. But each time you see a patient, that's where the test is. What is the test? The prescribing, right? And each test, are you prescribing in the right way? So we need to have a radical change in the way that medicine is taught, pharmacy is taught, nursing is taught, veterinary sciences are taught, and allow an approach-based learning. Fortunately, this is happening as we speak with the competency-based curriculum. We need to involve arts and science students into an awareness program with competitions, and we already have similar kind of clubs that we started in React, our network, and I'll just show you a few pictures in the next thing, where we created clubs where students can involve themselves in such public health measures. It need not be only about AMR, it could be about hygiene, it could be about aware health education itself, good nutrition, etc. So I think that's very important that we as community leaders, and when I say leaders, whichever profession you're in, we are acknowledged as leaders in whichever area we are, in our own families maybe even. So I think we need to move forward with engaging students. Last but not the least, we need to engage policymakers and also the pharmaceutical industry. This is very important because we all know that our policymakers are extremely tied up with lots of crises at the same time. But unless we make them aware about this particular crisis of AMR, I think we often will find that there are certain projects done, certain people are enthusiastic, but things do not move forward. So I think that's very important. We need to make sure that the medicines that we take are quality, both from a counterfeit and a substandard. Unfortunately, many of our drug control officers are doing their job in trying to ensure this. We need to make sure that many of the fixed drug combinations that we take are rational. Fortunately, there has been a lot of movement in this the last 3-4 years with various irrational drug combinations, not just antibiotics, being banned. I think we need to really look at this and see, is it the right dose? Is it the right combination? Do we really need this combination? The promotional methods that all of us face when it comes to incentives for prescribing or dispensing, do we really need it? Can we look at ourselves and say, are we doing justice to the system? Are we doing justice to the patient by giving an unnecessary antibiotic? And last but not the least, for all of us sitting here, can we have a code of ethical practice as far as antibiotic use is concerned? Let's not forget the other sectors, because all of us, whichever sector, whether it's the human sector, the agricultural sector, the animal sector, the food sector, the environmental sector, all of us have our own challenges as far as antibiotic use is concerned. And I don't want to get into a blame game, because every area there is misuse, there is inappropriate use, but everybody has their own context, everybody has their own challenges, everybody has their own reasons. But each in every sector need to look at those reasons and challenges and try and surmount them. For example, in other sectors, benchmarking in farms and food industry, easy to say, but when there is micro-farming, difficult to do. How can we address that challenge? Intersectoral experience sharing and problem solving often lead to blame games, but at the same time, we can sit together, we'll realize that actually we need to do things together. And last but not the least, where does our pharmaceutical waste go? How can we improve that? And I know that this is, again, a very great challenge. It's not just in the pharmaceutical industry, but many industries, the disposal, even our houses. Where do we dispose drugs? Where do we dispose food? And these are issues that as a nation which is building up, I think we need to address it in order to sort out not just AMR, but many other problems. So, the last slide, ECM, enlighten. We need to be able to, and as Dr. Anuj moves forward with his presentation on the Global Action Plan, the National Action Plan, we need to realize that these big plans are extremely important, but on the ground, community action, stakeholder action is needed through a personal connect with the issue, to be able to continuously engage, and not just for the moment, not just for today's session. We need to be able to communicate things in a very clear and cultural context. We need to be able to network, and this is extremely important. I'm glad that there are so many people from different walks of life attending this session, because that networking often becomes very important. Ultimately, though, we do need champions, and I want all of you to take up that challenge and see, can you be a champion for AMR, for your own hospital or wherever you're working, for your own community. And last but not the least, I think the belief that we can do something, it's not all lost. The hope is important. And at the end of this session, I think we're going to have a success story, and that will probably help, hopefully inspire people that they can also be a success story. Can we save the antibiotics that save us? That is the challenge that I place before you. Thank you very, very much.
Thank you very much, Dr. Sujith Chandy, sir. So basically implement different strategies, but to implement this antimicrobial stewardship in a community where the regulations are not very well laid down and OTC medicines are there, and sir has already mentioned regarding the disposal of antibiotics is also very difficult. A lot of times we see in the public health hospitals, in primary healthcare centers, where we supply the antibiotics. After a certain time they may not use it, but they don't know how to dispose. So these are the things that are happening, and their guidelines implementation is further difficult in the communities. So whatever suggestions, as Dr. Chandy sir suggested, has to be implemented in a community level where the message should be very clear. And again, we have to emphasize that diagnostics play an important role to guide the clinician to treat the patients. So these diagnoses should be made available in the community. The guidelines has to be percolated down to the primary healthcare level and other community setups, and end user also should be made party to this program. Like patient should himself should say that is this antibiotic okay for me or not. So that sort of awareness we should create, not only involving the doctors and other healthcare providers, but apart from that, the end takers, those people who are administered with the drug medication also should be make party to this to make it more effective in community setup. In a hospital context, we can regulate well, but in community setup, I think we need the participation from the public also. So our responsibility as rightly told by different stakeholders, to educate the community also regarding the antimicrobial resistance, polypharmacy, and using different combination of medications, changing the medication. All these things should be told to the public also, and they should also make to the party to the decisions. I think very well taken, sir, your point. And it's a long way, as you said, actually, this implementation going a long way. And the next talk, I think we are eagerly waiting. Dr. Anu Sharma, who is actually country head of the WHO Technical Committee, is, I was telling in the beginning also, the policy needs persons. So he is the person who is behind this policy, and we are really looking forward for his leadership in the driving this program across the country. Over to Dr. Anu Sharma for his presentation on the antimicrobial stewardship and antimicrobial resistance prevention.
I will be talking about global and national action plans on AMR and state action plan for AMR in Telangana. So I think AMR is a global pandemic, and it's a silent, as Dr. Chandy mentioned, it's a silent, invisible pandemic. A lot of people don't even realize how many people are dying due to AMR. And the reason is there aren't ICD codes which are implemented as yet. WHO has developed ICD-11, which was supposed to be implemented from January 2022 onwards, but I think the pandemic has delayed the implementation. So hopefully in future we'll have more accurate statistics on how many people fall sick due to drug-resistant infections and how many die due to them. But till then, we only have estimates. And the estimate 6 years ago from the Jim O'Neill's review on antimicrobials talks of, at that time, 700 deaths every year will become 10 million deaths every year by 2050. To put that figure into perspective, the COVID pandemic has, till date, in the last roughly 2 years, killed approximately 5 million people. So imagine 10 million deaths every year. Only due to AMR, AMR will become the #1 cause of death. 1 death every 3 seconds, with a huge economic cost, $100 trillion US, roughly 3.5% of the global GDP. And it's much more important for us because in India, we are in Asia. Out of those 10 million deaths, 4.7 million will be in Asia. And a large chunk of this, a rough estimate, 2 million will be in India. So for us, it's even more important to put AMR systems in place. Again, AMR cuts across sectors, human health, animal health, food and the environment, because you have AMR bacteria causing human infections, animal infections. They spoil the food, and they are also found in the environment. And antimicrobials are used only in human and animal health, but you will find the residues in the environment and the food. And also, only 30% of the antimicrobials are used in human health and the rest in food animals. And a lot of antimicrobials actually used in aquaculture sort of leach out into the environment, and environment has other sources of contamination from the pharmaceutical waste, the waste from the human and the animal excreta, which goes into the waste system, and also the household waste containing unused or expired antimicrobials also reach the waste. So environmental dimension of AMR is also increasing. WHO identified AMR as a priority way back in 2001 when it came out with this global strategy for containment of antimicrobial resistance. A beautiful set of 66 recommendations cutting across all sectors. Environment was not identified as an important area at that point in time, but all the other recommendations are still very valid today. Unfortunately, it was released on 9/11 and it didn't get the focus or the attention that it deserved. But then in 2011, it was the theme of the World Health Day, and it was a lot of sort of work started on AMR after 2011. In 2015, WHO came out with a resolution to develop a global action plan on AMR, and in May 2016 at the World Health Assembly, WHO released this global action plan on AMR, and at that point in time, India's Health Minister, Shri J.P. Nadda, was the President of the World Health Assembly when this was endorsed by all the 194 member states of WHO. 5 pillars of the Global Action Plan: awareness and understanding, knowledge and evidence, infection prevention and control, optimizing use, innovations, and R&D. Again, in addition to these 5, there are certain other overarching areas which have been addressed in India's National Action Plan. But before that, in September 2016, the UN took note of AMR. And 4th time ever a health topic was featured on the United Nations General Assembly agenda with this high-level meeting on AMR, and it led to a political declaration by the heads of states, leading to a UN resolution and the formation of an interagency coordination group on AMR. And this, in fact, changed the narrative. Up till that time, AMR was considered a technical issue. From this technical issue, from a health issue, it became a global development agenda issue. We had a lot of champions, the tripartite plus, as well as a number of countries which were championing AMR, but there were critical amplifiers, other UN organizations, the World Bank, a number of bilateral collaborations on AMR. India has bilateral collaborations on AMR with 7 countries: USA, UK, Sweden, Netherlands, Norway, Australia, and Japan. And also private sector also became involved after this UN high-level meeting on AMR. In fact, McDonald's and the other fast food giants have set a time limit on phasing out antibiotic-containing meat in their fast food chains. Coming to India, in 2016, we came out with this background document, AMR and its containment in India, the first sort of scoping report on AMR, which actually formed the backdrop for India's National Action Plan on AMR, along with Delhi Declaration on AMR, which was signed by 4 union ministers, and is the de facto political commitment or the AMR policy of India, which were launched at the Interministerial Consultation on AMR in April 2017. And this was before the May deadline of 2017, which the Global Action Plan had asked all countries to have national action plans aligned to the Global Action Plan. In India, we have a huge number of stakeholders working on AMR. A lot of them are the government ministries. Of course, the Ministry of Health is important, and a number of key stakeholders: ICMR, NCDC, the National Health Mission, the Food Safety Standards Authority of India, CDSCO, the drug regulator, Indian Council of Agricultural Research, of course the tripartite plus in India, the WHO, FAO, and the UNEP. We don't have OIE at the country level. And of course, a number of other initiatives and a number of state governments as well. India's National Action Plan, aligned to the Global Action Plan, in addition has a 6th strategic priority on collaborations, looking at international collaborations, national collaborations, and most importantly, state action plans on AMR. And I'll come back to the state action plans on AMR in a bit. But all these areas cut across sectors. The focus areas, 16 focus areas, the ones with the white background, cut across sectors, not just human health, food, animals, or the environment, but across all the sectors. The reason state action plans are important in India: under the Indian Constitution, we have 3 lists. The union list, where the central government looks after 97 issues. The state list looks after 61 issues, and the concurrent list 52. And under the state list are 4 critical issues: health and sanitation, agriculture, animal diseases, and fisheries. So you can imagine, for action on the ground, we need state action plans. So till we have state action plans on AMR, we will not really have action on the ground. So the Ministry of Health also came out with this guidance document on how to develop state action plans on AMR, and simple steps mapping AMR stakeholders, have a state workshop as an information sharing to draft the state action plan for containment of AMR, develop a background document on the basis of the state workshop, put in place governance mechanisms who will oversee and ensure action happens, and then have a state consultation with a wider a group of stakeholders to finalize the draft SAFCAR. In India, Kerala was the first state to develop its state action plan, KARSAP, the Kerala Antimicrobial Resistance Strategic Action Plan, launched by the Chief Minister of Kerala in the presence of the Additional Chief Secretary Health and the Health Minister. And this was in October 2018. The next state to come on board was Madhya Pradesh, a state action plan for containment of antimicrobial resistance, MP SAPCAR, and this was in July 2019. And Delhi was the third one with SAPCAR, the state action plan to combat antimicrobial resistance in Delhi, in January 2020. Immediately after this, end of the month, we organized a regional workshop on AMR using the Kerala experience and the Kerala stakeholders to get these 7 states and 1 UT in the southern region to develop their roadmaps for state action plans. And this also saw the launch of the KARSAP report at this event. Now, coming over to Telangana, it's important to understand that the Kerala state action plan for containment of antimicrobial resistance has a number of stakeholders. And the most important would be the government of Telangana, the policy makers, the politicians and the bureaucrats, the farmers and the public, and of course the professionals in health, animal health, agriculture, food and the environment. And again, the key departments are the health and family welfare, looking after hospitals and medical colleges, animal husbandry, dairy development and the fisheries department, looking after veterinary hospitals, food institutes and the labs, and the environment, forest and science and technology department, looking after the Telangana State Pollution Control Board. In addition, you have the Department of Agriculture, the Department of Food, Civil Supplies and Drug Administration, Higher Education, Public Health and Municipal Engineering, universities and research institutes across all sectors, professional councils at the state level, the Medical Council, the Veterinary Council, Pharmacy Council, the Nursing Council and the Dental Council, professional associations across all sectors, in healthcare, not just looking at doctors, but also microbiologists, nurses, and other professionals. NGOs and civil society like REACT, Center for Science and Environment, MSF, pharmaceutical associations, and the private sector, not to forget the private sector in India, which is responsible for delivering roughly 70 to 75% of care. Of course, at the national level, you have NCDC, ICMR, Department of Biotechnology, who will provide support, the drug regulator, ICAR, Department of Animal Husbandry and Dairying, and the CPCB, the Central Pollution Control Board. And of course, WHO, FAO, and UNEP will be there to provide support. But you already have some champions in the state, the Nizam's Institute, the University of Hyderabad, CMC Vellore with 3 speakers today from CMC Vellore, the Infection Control Academy of India, Superheroes Against Bugs, Against Superbugs, and REACT, and of course WHO India office. So the SAPCAR in Telangana has very simple steps. The stakeholder mapping for a One Health AMR containment in the state has been done. This has been shared with the key stakeholders, and hopefully this will get translate into the next step to have an information sharing workshop, inviting all the key stakeholders to look at the situation, to identify the key priorities from the state perspective, and then put governance mechanisms in place, have state nodal officers for AMR in each sector and each priority to draft the state action plan on AMR, followed by a stakeholder consultation to finalize the state action plan. So my last slide, I would just like to emphasize, AMR is a global, national, and a WHO priority. And state action plans with a One Health approach are critical for AMR containment in India. And for Telangana state, we hope that the government continues to provide support, and we look forward to Dr. Gangadhar for his support in ensuring the government oversight and engagement of key stakeholders and their ownership for AMR containment. And in parallel, I would also propose that surveillance be started even before you have a state action plan in place. Ensure that you have a state network for AMR surveillance in human health, animal health, fisheries, food, and the environment. Also ensure that you are looking at antimicrobial consumption in health and in animal health as well, and antimicrobial use as well in all the sectors. So I would like to end here, and before I end, I would like to remind you that 18th to 24th November is the World Antimicrobial Awareness Week, and the slogan is handle antimicrobials with care. The theme of the WOW campaign this year is spread awareness, stop resistance, and one of the key initiatives to raise awareness amongst the public is that 24th November is the Go Blue Day. So I would urge all of you to wear light blue in any form to express solidarity and raise awareness about AMR. Use your social media profiles, use your interactions with the public to show that you are wearing blue because you are raising awareness for AMR. So thank you very much.
Coincidental, I got a call from Health Secretary for preparing a small note on AMR because he is currently attending a meeting of Southern Regional Conference. Southern State Review is happening at 6:15. I need to just prepare a small note and give it to the government. I think it's an apt point. It's maybe coincidental, but your inputs are taken. I think our government of Telangana is fully committed from the point of antimicrobial resistance to creating the awareness, taking the antibiotic stewardship, and having intersectoral collaboration with other departments also will be planned, and in gradual fashion we'll try to implement the state action plans. And first, from the beginning, I was emphasizing that people matters. Until unless people are there to drive this sort of a programs, it's very difficult to implement policies. Policies remains on papers. Until unless people are there, they will not go to the implementation level. I think a committed person like you sitting at Delhi, guiding all the states, to implement and prepare the state action plans. It's very important to drive these programs to the public so that all the public at large will get benefited out of this sort of interventions. And Dr. Sujith Chandy sir was telling, this COVID is only a kind of it will be there for a few years and after that it's go. But this AMR remains to stay. I think we need to sensitize the governments, understanding that is a threat, and then a threat perception will drive the government machinery to take action. I think we should be able to drive this message to the governments that AMR is going to be a problem in future and it's going to be a persisting problem where we need to act together. Apart from health department, we should take on board with the other departments also where this the problem is cropping up. Maybe animal health or at a community level or a pollution control board. So all this and drugs and pharmaceuticals where the drug disposal is a problem. So it's an effort, a multi-sectoral kind of intervention is needed to control the antimicrobial resistance, because this is going to be a problem which will be persistent. Already we are perceiving. Last time I also told, as a nephrologist, to treat a urinary tract infection is equivalent to doing a transplant. So UTI treatment with the so many drugs and your drugs, it's costing more than ₹1 lakh or 1.5 lakh. With that same thing, we used to do a transplant also. So this is problem is already perceived by so many people. I think we should be able to address the problem in a more holistic fashion. And thank you very much for your guidance in this angle. Since last 1 month, you met our health secretary also here, and just now he called up, I informed that you are with me. So we are trying to put up the program in our state, and some states already put up the program in like Kerala and other states. We'll try to learn from them and we'll try to improvise further. So going to the next program, we have one case study. I think already we have implemented rational use of antibiotics, usage and quality improvement, and experience from Telangana. I think we have with us Dr. Yadaya, SNCU Medical Officer from Nalgonda, and Dr. Salima, Health Specialist of UNICEF, Hyderabad. We request you to come onto the dais and explain the rational use of antibiotic usage and quality improvement. And Dr. Yadaya, I know him personally well. He got an award for the best SNCU in the country for saving. With a round of applause, we invite him to the dais and share his own experience in rational use of antibiotics. Over to Dr. Yadaya Garu and Dr. Salima. Yeah.
Thank you, sir. So I think I'm going to speak using this mic and speak from here so that I can see all of you very well. You know, since the session started, we have been talking about implementing and champions. Dr. Chandy very clearly shared that, you know, we've just started and it's important to create, you know, do something, create those islands of excellence. And today, what we want to present to you is one such island of excellence that has, and our champion, Dr. Yadaya, frankly, who's been doing all of the work and implementing and doing his bit to this particular agenda. So I'll just give you a short overview and then I'll hand it over to Dr. Yadaya to kind of take things forward. UNICEF, but of course, is committed globally and nationally to the agenda of AMR. And because we work in the area of maternal and newborn health, largely child health, we picked up the area of SNCU, Special Newborn Care Units, to demonstrate this particular activity, or where we wanted to start the intervention on AMR. You just heard Gangadhar mention that, you know, our SNCU was one of the first, or rather the first in the country to actually receive NNF accreditation. It started from there and it was a journey. The first step was you try to look at saving lives. So when you start any intervention, you first look at establishing, then you start looking at quality, and then you slowly start moving towards indices and better quality and quality improvement. Again, I'll come back to Dr. Chandy's point, where he said that indices, he's not very happy with indices, but indices do help. Because you can see here, Telangana was second best in newborn care, as per the as per this indice, which basically took into consideration 7 points. One of the points was rational use of antibiotics. And we realized that that's one area where we are not doing that well. So to make sure that we moved to that next level and make sure that we moved to the next step, I'm sorry. This intervention, Government of Telangana actually initiated the QI mission. And as part of the QI mission, we initiated a QI project on AMR in SNCU Nalgonda. So there were 10 SNCUs, different SNCUs picked up QI projects on different areas, and SNCU Nalgonda picked up a project on AMR. What is very interesting to see is that as a result of the implementation of the QI project, which started, so the index was in 2017, in 2018 the QI mission was started, and for 2 years the project was implemented very, very strongly. It's still going strong. And what happened as a result of that is that not only the antibiotic usage reduced, so we got down from say a percentage of 22% to 2%. That's the kind of reduction in the SNCUs in terms of antibiotic usage. But what also happened, thank you sir, But what also really happened was that it decreased the workload of the staff nurses. So they started liking the initiative. And that's what collaboration really brings forth. That this cannot be implemented in silo. We've been talking, Dr. Anuj has been really highlighting how important it is to get all stakeholders together. And this is a perfect example of that. And lastly, something that we've not really looked at very closely is increased savings. Within SNCUs, in some of the SNCUs, the amount that was spent on antibiotics started, there was a reduction in that, and now they had money to start using that particular amount for higher end interventions on for other medicines which were probably not as easy to find, of course. So that's the background, and I just want to sort of say that the momentum has been going on. In fact, it's very nice to see that the state took up this initiative. They released the state antibiotic policy for newborn units in Telangana in 2021. And then we brought the IAP. I mean, the Indian Academy of Pediatrics has been leading this initiative even otherwise. In Telangana, the Twin Cities branch, this chapter, they came up with this concept of RAP stars, rational antibiotic prescribers. So these are the RAP stars, and on 12th September, I believe, they had these 26th September, 12th September, they had this Rational Antibiotic Day celebration. So the journey really continues. And when we talk of champions, this is an example of champions. There's a long way to go, but this is the beginning that has been made. Over to you, Dr. Yadaya. Thank you.
Thank you, Selma. Because I had the privilege of hearing very good lectures from CMC. Thank you for the invitation. And coming from the rational use of antibiotics, antimicrobial resistance. It was in 2015, the UNICEF did a survey in both states of Telangana and Andhra Pradesh. The use of antibiotics across all the SNCUs. It was somewhere around 65 to 98%. Then we thought of why can't we reduce antibiotics in situations where neonatal jaundice are just babies admitted for observations. So rational antibiotic is, as all of us know, should take the right patient, right drug, right dose, right route, right time, and right duration at the right cost. That's what is rational. Any antibiotic used where there is no clear indication, it is irrational. And not using antibiotics where it is indicated is also irrational. So right drug and that upgradation and downgrade at the right time, this all includes rational antibiotics. We at SNC in Nalgonda, when we thought of rationalizing antibiotics, we made it just simple one rational antibiotic justification form. It is just nothing. What are how the patient admitted, the details, maternal history. And if at all you suspect or decide to give antibiotics with a clinical sepsis, as we do not have any investigations, It's a very limited resource setting. Depending on the maternal history and the examination of the baby, just to start antibiotic, it's purely empirical and the clinical diagnosis. The one thing is what the consultant, whoever wants to put the antibiotics, they have to go through the justification form, should complete the justification and start the antibiotics. And the name of the antibiotics started under what conditions, empirical or because we don't have any culture. Only thing sepsis screen was the only investigation it was available for us. This is PDSA cycle justification form and good infection control practices and regular trainings. And this is in 2017 when we started. It's throughout Telangana. It was in 2017, if you go to the SNC online data, which is the biggest data in the country, 45.3% of all admitted babies were given antibiotics, against the culture positive sepsis 7%, which is truly irrational. In fact, that made us to start this rationalizing antibiotics. This is the data in 2017, where 54.7% were given antibiotics, and 45.3% were given. This is the data of SNC in Nalgonda in 2018, where 23.4% was antibiotics were given, and we have decided to cut down the antibiotics by 50% in the next year. This is in 2019, and surprisingly, we could cut down the antibiotics 2.2%, which is not believable. Simply what we have done is, we stopped giving importance to CRP, C-reactive protein. Whenever the people say CRP, they make it a highlight with the marker and give a lot of importance and go for the antibiotics. CRP is useful when it goes at the time of prognostication or improvement, and we really don't believe that it's just an inflammatory marker. Then we started not giving importance. We have sensitized all the doctors working with us, then let us stop giving importance to CRP and see a clinical examination of the baby. Let us go to some maternal history and then put the antibiotics if really needed based on the clinical examination. That given wonderful result when we cut down to 2.2%. This is the antibiotics at SNCU from 2018, April 2018 to March 2019. You can see how it has come down. This is 2018, 17-18 and 18-19 data. And the latest data is yet to update. In 2017, 226 babies were put on antibiotics, which comes to 22.2%. And 2018-19, it was 57 patients, that was 4.9%. 19-20, it is 2.1%. That's 33 patients of the total. And coming to the cost per the day, it was 315, 216 and 280 rupees per the patient. The duration of the hospital stay was 9.1 days in 2017, 8.4 days, and it came to 5.8 days. There was reduction of stay by 3.3 days in 1920. Total patient days were in 2017 it was 9,255, 9,694 and 9,402. And total antibiotic days from 2007 was 1179 antibiotic days. 1819 is 196 days. It's 158 days in 1920. So ratio of antibiotics to patient days is 0.12, 0.02 and 0.01. Coming to the conclusion, this introduction of justification form reduced antibiotic usage by 85.4%. And the antibiotic usage per patient was 86.6%. Cost of the antibiotic reduced by 89.7%. And the average hospital stay reduced by 3.3 days. Ratio of antibiotics from 0.1 to 0.01. The cost saved was 350 rupees INR. The cost of the intervention is justification was negligible, just 40 paisa, with some clinical interest and some passion to reduce the antibiotics. So rationalizing antibiotic usage, other benefits like improved survival by 10%, increased admissions, decreased duration of the stay, and decreased nosocomial infections, and decreased referrals, decreased biomedical wastage, and decreased workload on healthcare providers, and decreased pain and stress to the mother, baby, family, and healthcare providers, and minimizing the blood loss in the babies. So, we believe in maternal history and some good infection control practices, supportive care. Instead of going direct straight away to antibiotics, we try to take all the supportive measures and good infection control practices and put the baby on express breast milk rather than formula feeds and encourage breastfeeding, and no role of prophylactic antibiotics in neonatology unless in few cases of surgical interventions. Do not give more importance to C-reactive protein. Judicious short-term use of antibiotics gives more survivals. This is sustaining the momentum, like implementation of state antibiotic policy, regular review meetings, and the RAPSTAR champions, and the QA as the driver, samples for regular antimicrobial analysis, which is not available with us, and focus on the infection prevention to reduce antibiotics, and operational research and learning. And this is one of the baby, just we took it to say that antibiotic is not needed for a good baby admitted for some other reason. And antimicrobial resistance threatens the child survival, and children need access to effective life-saving medications to protect them from dangerous infections. But we must also prevent the spread of resistant pathogens by promoting the rational use of drugs, immunizing every child, and ensuring access to clean water and sanitation. Lives are at stake. There is not time to wait. Thank you very much. Thank you so much for giving me.
To go blue on 24th of November. UNICEF is anyways blue. That's our mandate. So we will make sure that, we take forward this activity on 24th November. So thank you. And thanks to Dr. Reddy for accommodating us at the very, very last minute. We just requested him 2 days back. So thank you.
Dr. Salima, for that wonderful presentation. May I now invite on stage Dr. Ranga Reddy Bhumi, President IFCAI, to please present memento to Dr. T. Gangadhar, OSD to CM, Government of Telangana. I also invite on stage Dr. Yadaya, SNCU Nodal Officer for Nalgonda, and also Dr. Salima, Health Specialist, UNICEF Hyderabad Field Office.
Thank you very much. Due to paucity of time, probably I will not speak much. Today's speakers, they have made abundantly clear how antimicrobial resistance is a big threat, not only to our state, India, but also to the world. And the excellent presentations, which are being done by all the colleagues, I think they made it very, very clear that what is the way ahead for all of us. I think the talks were not only knowledgeable and also informative, but they are kind of inspirational for all of us. I think we should definitely take this initiative forward and put an end to the AMR, which is a silent pandemic. I would like to thank, first of all, Dr. Gangadhar. Without his moral support and also the physical support, probably this event would not have happened. And I always get amazed at his the strength and also tenacity. I think he works like a robo, 24 hours a day. Night, morning, there is no difference. I think that's the kind of commitment probably which is required in order to handle such a big problem like AMR. And Dr. Anuj, who had been doing a very silent work, but also which is impactful work. I think that is what already is seen in several states, and we are lucky to have him here and also to have his support to bring out an action plan for Telangana State. Thank you, Dr. Anuj. And I would also like to thank Dr. Balaji, who has done an excellent presentation. He doesn't actually require any words actually to talk about him, because he is an international star in AMR in any case. But his presentation was abundantly clear on what is the way ahead for all of us. And Dr. Priscilla, as usual, a super duper presentation, which has really made us realize the truth behind the problem, and also, to understand at every level, not only the doctors, but also at every level and at every sector, how the action plan needs to be. And then Dr. Sujith Chandy, the ever-young man, who has not only energy, but he has kind of probably always, 2 inches under his probably arms, keeps flying, keeps actually giving all the kind of directions, but at the same time silently stays behind the curtains to make a lot of things happen. My sincere thanks to him for making it happen. And also, although it was a last minute kind of plan, but thanks to Dr. Salima, who is a good friend whom we had been working with for quite some time, and also Dr. Abhaya, although we never met earlier, but we had been in touch for quite some time, working on AMR front and also the IPC front. And I would also like to thank REACT, the organization who are behind actually this program. They did the first program in Taj Banjara about a couple of weeks back, which was the kind of program, sensitization program, which has evolved into this these days action, which is witnessed by all of you. I am sure we would not stop here. And also, I would like to recognize the presence and also the active support from superheroes against superbugs, who have done a tremendous job collecting all the information about the stakeholders and supporting this particular event and also the previous event. And numerous other silent heroes who have been behind the success of this program. And certainly we will not stop here. This is only the beginning. We would definitely take this forward. And with Dr. Gangadhar's support, we will ensure that the state action plan is going to be in place as quickly as possible, maybe maximum couple of months. And we will also take November, I would like to assure Dr. Anuj, we will also take up this November 24th global event as seriously. We'll see how we can collaborate with Ministry of Urban Development so that, at least Golconda or Charminar or something is lighted on 24th with blue. We'll see how we can actually differentiate from rest of the states to show our commitment and also action towards AMR problem. Thank you very much once again, and all the audience, excellent support of yours. I would remain. Thank you very much.
The memento to Dr. Anuj Sharma.